All right, so part two is kind of where the meat and potatoes is. Immediate treatment, burn center referral, airway, breathing, and circulation, right? So these are our severe burns that are coming in as a trauma, and these are the initial steps that we need to do. So I've already said this is the second time I'm saying this, but initial management follows the same principles of care as any trauma patient. You go through these systematically: airway first, breathing next, circulation, disability, exposure, and then your burn evaluation is part of your secondary survey. Now, everyone's going to have slightly different burn center referral criteria. I pulled this from a paper that this is kind of what they use. And so it's partial full thickness burn, which is going to be your second and third degree burns of greater than 10% in patients that are less than 10 years of age or greater than 50 years of age. Partial full thickness, so second, third degree burns that are greater than 20% in the rest of the population. Full thickness burns, which are going to be your third and fourth degrees of greater than 5%. Any burns to the hands, face, feet, genitalia, or major joints. Chemical burns, which we already talked about, acid and alkali. Electrical burns, or lightning strikes. Any chance of significant inhalational injuries. Circumferential full thickness burns to an extremity or the torso. Burns in patients that have chronic medical conditions like chronic kidney disease, congestive heart failure, COPD are going to be a low threshold to transfer. And then any burn patients that have associated traumatic injuries. So this is a nice starting point for criteria, but I would go with what your agency uses in terms of referring people to a burn center. So let's go through the ABCs. So airway. So the key question is intubation required to prevent airway obstruction? And the thing here is that we know that there's some predictors of the need for intubation. And the reason we talk about this is that if there's any significant burn to the oropharynx, that will begin to swell and then potentially occlude the airway. And so these patients, we need to have a low threshold for thinking about intubating them. Things that should make you more prone to needing to intubate are going to be a greater than 30 to 40% total body surface area, burns to the head and mouth, significant smoke inhalation, a delayed transfer to a burn center, altered mental status, and then any change in the voice, including hoarseness. For breathing, there's really two components here. So the key question is, does this patient have carbon monoxide poisoning? Now, ABGs and pulse oximetry, not going to be helpful in determining that. You actually need co-oximetry to find this. And the reason this is important is that the affinity of carbon monoxide for hemoglobin is 200 to 250 times the affinity of O2. And the way we try and compete with that is we put these patients on 100% FiO2 oxygen to try and kind of compete with that carbon monoxide and get it off of the hemoglobin molecule. The second key question with breathing is, does the patient have a smoke inhalation injury? Now, this is going to be hard to determine, but by history, is exposure to smoke in an enclosed space possible? And if the answer is yes, then again, you should have a low threshold to intubate the patient. Once the patient gets to the hospital, we can do things like bronchoscopic evidence of carbonaceous material below the level of the vocal cords. The thing to realize here is that acute lung injury and ARDS can occur and should be treated with low tidal volume, which is about 6 mLs per kilogram of ideal body weight, not actual body weight. And then the last component, and probably the biggest component, is going to be circulation. The key question is, what is the burn severity and what are the patient's fluid requirements? Most places are typically using balanced isotonic crystalloids, things like lactated ringers. Now, after the initial first 8 hours, you can start to use other things like albumin or plasma, but I would let your protocols determine when it's time to start using those. I already told you that most places use the Lund-Browder chart. Burns are frequently overestimated with other methods, especially in kids. Now, the charts used to estimate the initial fluid rate, they do not count superficial burns. So those first degree burns do not count as part of the total body surface area that's included. Now, after you do your initial 8 hours, you certainly can start fluids at what you calculated for what they need for the remaining 16 hours. But really the fluid rate is going to be dependent on the urine output, which we'll talk about here in just a second. After the initial 8 hours of volume, you adjust your fluid rate to urine output. And the goal here is 0.5 mLs per kilogram for adults, and it's 1 ml per kilogram for children less than 30 kilograms. And this is per hour for both of these. Now, there's several formulas out there to calculate this. Again, I would go with whatever your agency's protocol is. Some people like the Parkland formula. It's the one that's probably the best known. It's used for deeper burns. It guesstimates a 4 ml per kilogram total body surface area, with the first half of that amount given in the first 8 hours from injury and the remainder given in the following 16 hours. The Brooks formula is another one that is typically used, and it's used for less deep burns. And you can see that this one is 2 mLs per kilogram per total body surface area, again with the first half given over the first 8 hours and then the remainder given over the remaining 16 hours. Here's two patients that are exactly the same, and I just kind of wanted to do the calculation here for you. So if we use the Parkland formula and we have a 100 kilogram patient with an 80% total body surface area burn, that's going to basically be 4 mLs times 100 kilograms times the 80% total body surface area. That is 32,000 mLs in 24 hours. If you divide that by 2, that tells you need to give 16,000 mLs in the first 8 hours. And if you divide that by 8, that tells you that's going to be 2,000 mLs per hour. If you use the Brooks formula, it's going to be exactly the same calculation, except you use a 2 here instead of a 4. And what you see is 2 times 100 times 80 gets you to 16,000 mLs in the first 24 hours. Divided by 2 gets you to 8,000 mLs for the first 8 hours. And then the starting rate is 8,000 divided by 8 is going to be 1,000 mLs per hour. Now, the key here is to remember that that first 8 hours is from the time of the burn and not from the time that you're evaluating the patient. So burn management, part 2. Severe burn management is part of the secondary survey, not the primary survey. These patients are treated like trauma patients. Know the criteria at your local agency for burn center referral. Intubation early is required to prevent airway obstruction, so have a low threshold in those patients where there's any concern. Acute lung injury and ARDS can occur with smoke inhalation that is significant. Know your patient's fluid requirements. Again, use whatever equation, Brooks or Parkland, whatever your agency is using. After the initial fluid correction, titrate fluids to urine output. There are several formulas to calculate fluids. Use what's in your protocol.